All right, good morning, everyone. This is a new topic and a new field uh, that our students are expected to not, most especially our undergraduate student that are in part one and part two. The topic talks about forensic counseling, but this one is going to talk about how to counsel a forensic client. As usual, a forensic client needs attention, and a counselor is expected to give him wrap attention as a professional. Let us look at the counseling process. First and foremost, a counselor is expected to look at the introductory step, that is the preparatory stage on how to receive the client. That is what he or she is expected to do as a professional counselor. Doing that will give the client an ample opportunity to at least brace up in order to solve his problems. Uh, As you know, introductory or preparatory stage is a stage that gives a counselor information about the client, and is the stage that the client is expected to voice out or to ventilate, or at least to tell the counselor his problem. So number two is assessments of formulation. You are expected as a professional in the field of psychology to assess the client that is in need of your assistance. Number three, you are to set a goal. Goal setting, treatment planning. As a counselor, you're expected to set a goal that you're expected to achieve before the end of the counseling session or before the end of the therapy. So if it is a therapy, it takes time, and it's a treatment that needs time for the wounds to heal also. So the next thing is intervention. This is where you are going to bring out your counseling skills, your counseling techniques, your counseling experience. This is where you are expected to bring out all your arsenals in changing a behavior or correcting a pattern or habit or something that has to do with that. Because in an intervention or working pace, this is where you're expected to bring all the teachings of therapies or therapy that you have with you, all the theorists that have propounded many things in behavioral changes or for behavioral changes or changing. You are expected to look at what they said and bring it here so that the client will be healed accordingly. Working pace, this is where the real counseling work starts. This is where you are expected to put your thinking cap as a counselor. It is where you are expected to start using your equipment, to start using all what you have at your disposal in order to help the clients. And the next thing is monitoring and review stroke adjustment. You are expected to follow up. Your follow-up stage helps a lot in monitoring what the client is passing through. If it is something that is encouraging, you guide him, and if it is something that needs to be changed, so you are expected to at least change that particular topic, that particular technique, or that particular method that you have adopted for changing a behavior. So, number six is termination, transition, and transfer. You can terminate a case if you have finished treating the case, and the transition and transfer. If you cannot solve a particular problem, you are expected to at least refer the candidate or the client to a more qualified person that will help him. Number seven is post counseling evaluation. Although I have mentioned in stage five, monitoring, stroke review, and adjustment. Yes, this is another stage, the last stage, that is post counseling evaluation. You are expected to evaluate uh, the progress of the client. You are expected to at least interact with the client to see whether is recuperating or there are challenges they expected to at least adjust or correct. Preparatory stages I've mentioned, introductory stage, what to do, what you're supposed to do at this stage. You are expected to establish rapport between you and the clients. So if you look at this, establishing rapport is the first thing they're expected to do. how do we do that? Is by cracking jokes. Use your social skill here by smiling to the client, by making him feel comfortable and feel accepted. You can hug him if the client is not from your opposite sex. You can still advance your ways of giving him seed, of giving him something that will catch up his attention so that he can tell you his mind. So establishing rapport in the counseling session is the key thing that a counselor is expected to do. If you didn't take your time to establish rapport between you and the client, I'm telling you, you may not achieve anything before the end of the counseling, because this is where you're expected to win the mind of your client so that the client will tell you in depthly what he has concealed in his mind. So establishing rapport is just like establishing a concrete foundation for your building. So it's good for a counselor to understand this. You can establish your rapport. Everybody has his own way of interacting with people. But the most important thing, that unconditional positive regard between you and the client should be established. You should not look down upon him. You should not look at him as if it's something that is facing problem. So he's coming to you as a problematic person also. So what you're expected to do is to accept him holistically and without discrimination also. So another thing is informed consent. There is what we call informed consent. Before you start counseling a client, there is need for you to at least get his informed consent. He should give you his information without you forcing him or compelling him to tell you about his information. No, that should be informed consent. So that's why we have informed form. We have the intake form where we give it to a client to respond, so that if there are things that he has not corrected, he may correct them at that particular stage or so. Another thing is gather history. You should look at the history of the problem. Maybe the client might have experienced that in his previous years. You can do that by taking your time to at least uh, elicit information from his past experience and so. Number four, risk assessment. Risk assessment is a process of estimating the likelihood that the person will engage in harmful behavior to solve or others. So there is need for you to do that as a counselor. You assess the risks that he may afflict to himself or to others in a specified period, and identifying factors that heighten or mitigate that risk. So HCR 20, historical clinical risk management. This is what we're expected to note. As a counselor, you are expected to take a history. You are expected to talk about the clinical aspect of the behavior and risk management of the client. These are some of the things that we are expected to do. If you take a look at this diagram, this is an assessment stroke formulation of three different diagnoses: biopsychological or biopsychosocial. So if you look at it, this is what this one has to do with bio, that is um, anything that has to do with life and so. Psycho, that is mind and so, and social, that is uh, interacting the way an individual interact with people. So we have bio, we have psycho, we have social. So bio, psycho, social. So if you take a look at it, it has stages that you're expected to follow. If you take a look at the left side, where the red background, like predisposing issue, precipitating issue, perpetuating issue, and protective issue. We have step one, we have step two, we have step three, we have four, five, six, and seven. So this is just a diagram representing an idea. We are going to talk on that idea so that our reader will get to understand what is there. So now this is the explanation of the diagram. The first side by the left, the top right or the top left hand side is components. So under it we have predisposing factors, we have precipitating factors or triggering factors, we have perpetuating or maintaining factors. So some behaviors are just like that. There are precipitating factors. So if you look at the description, what vulnerabilities or background factors made the person more susceptible? That is genetic, early life, adversity, temperament, and personality. So some people are just like that. There are things that push them to a certain behavior. So a counselor is expected to look at the predisposing factors of a client. Maybe his problem is genetically motivated. Maybe his early life adversity that he has encountered. Maybe he has a temperament or his personality. So a counselor is expected to look at these things in the course of helping uh, a forensic client. So number two is precipitating factors or triggering factors. What recent events or stressors set up the current problem, e.g., loss, trauma, job stress. So, are there recent event that happens to the client, to this client that is before you? When we talk of forensic counseling, a client, we are referring to individuals that have found themselves in the process of lawsuit, in the process of justice demand, or in the process of all people that are even jailed uh, in in the correctional center. And so a client is expected to interact with them. Now, if you have been sent to correctional center, these are some of the things that are expected to know. What are the predisposing factors that push that person into prison? What are the precipitating factors that is triggering his behavior? And not only this, there are perpetuating behavioral factors. What processes or behaviors or beliefs or environmental factors that are keeping the problem going? E.g., avoidance, maladaptive coping, negative or belief, and interpersonal conflict. So maybe the person keeps on doing the same behavior, keeps on repeating certain behavior that's not accepted in the among our people. So sometimes somebody will serve a jail term, and so after some period of time, you see him coming back into that particular jail or correctional center. So what are the perpetuating factors that are pushing him to do that? Uh, if we take a look at this, there is protective factors, that is resilience factors. What strengths, resources, support, or mitigating factors help buffer risks and support recovery? So, as a counselor, you are expected to design something that has to do with that recovery plan. How do we do that to mitigate future occurrence of that particular behavior? What are the strengths of the clients? And what are the resources you're expected to put in place in order to guide him in the course of recovering him from this problem? What kind of support are you going to give him? So we call it protective factors or resilience factors. And not only these, hypotheses stroke mechanisms. How do you believe the above factors interact to cause and maintain the client's symptoms stroke problems? What are the key mechanisms, e.g., cognitive distortions, emotion dysregulation, interpersonal patterns? What are those things that you can at least foresee in the course of interacting with the client also? Implications for treatment. If we take a look at this, based on the above, which intervention targets should you prioritize? That is implication for this one. Implications for treatment. There are implications at the end of everything. So, based on the above, which intervention target should be prioritized, or should you prioritize? There are different there are different intervention targets that you're expected to use. So, as a psychologist, you give it a very closely or cursory look, a very close look, so that you should be able to at least target an intervention that prioritizes your whatever or what you're doing. What strategies are indicated? What needs monitoring? So these are some of the things In the course of counseling him, in the course of interacting with him, there are other things that needs monitoring so that that particular behavior can be corrected or changed. Another thing is goal setting, stroke treatment planning. So, as a counselor, you have to set a goal. You have to set a treatment planning so that that particular behavior can be enhanced or can be achieved. There is what we call negotiation. If you take a look at this, we call it negotiation. I would like to be able to work my grandson to school. So this is just goal negotiation, and not only this. If you take a look at this green, whatever goal setting, I want to walk 100 meters without stopping. Number three, that is planning, prescription of walking program to progressively increase continuous walking distance and duration. Not only this, if you take a look at action, carry out working program. So this is the action you are taking. And the next thing is appraisal and feedback. So accelerometer based monitoring of daily activities shared with physiotherapists and patients. So these are some of the things that you can use as a counselor in order to track the goal of that particular problem that you want to at least help. Goal achieved, you should ask yourself yes or no. If the goal hasn't been achieved, okay, if you say yes, you are going to take it that way, the way we've said it, or if you say no, you are going to take it, you are going to replan again. But this thing start from all goals achieved. So if all goals are achieved, then you are lucky, you don't have any problem. But if goals are not achieved, then this is how you are going to take it. You are going to take it from here. You are going to take it one after the other up to the end. You now take no, so that you can see it very well. And I believe by so doing, if you follow it very well, a behavior can be solved within a short period of time. It's just left for you to at least implement it very well. Steps in goal setting, there are steps. If you want to set unachievable goals, there are steps. Number one, collaborative goal setting. Short time, intermediate, and long time goal setting, and so ensuring goals are client centered and meaningful. Sometimes goals are not client centered. So when we talk of client centered, all the whatever that you are planning, the short time, immediate time, or long time goals, it should be centered on the needs of the client so that the problem can be solved amicably. Number two is prioritization. Some issues must be addressed first, e.g., safety risks. You must prioritize this before you now continue with your work as a counselor. Decide which goals are essential versus optional. So you should be able to understand this. And not only this, number three, we have SMART. SMART, this is an acronym or a mnemonic that helps us to at least implement our plans and so. So SMART goals. Number one, S stands for specific. The objectives of the planning that you are expected to do, it should be a specific planning, a planning that helps a lot. And not only this, the planning should be measurable. You can measure its progress, how many days, how many months, and how many years. How do you intend to achieve it? You have to measure that particular process. And so, is the planning achievable? If the planning is not achievable, you don't waste your time. So we plan something that we are expected to achieve. You cannot plan for something that you cannot achieve it. And not only this, is the planning relevant? So if the planning is not relevant to the client's goals, to what you want to achieve, maybe you want to change a behavior and it's not rhyming, it's not going together with it, what are you supposed to do? So you should be able to look at it. And time bound. Time bound, your planning must go with time. I want to do this particular task before the end of the day. I want to do it tomorrow. I want to do it in 5 days' time. I want to do it in 1 week time. I want to do it in a month. And I want to do it in 6 months' time or 3 months' time also. So you have to make it a time bound goal also. Number four is modalities of intervention selection. Choose therapeutic approaches aligned with goals, e.g., CBT, cognitive behavioral therapy, or trauma therapy, or relapse prevention. for those that are taking substances. So cognitive behavioral therapy, that is CBT, is very helpful. In fact, it's helpful. It helps a lot to change a particular behavior, but it has different techniques that you are expected to learn how to make use of it. And Aaron Ben is the proponent of this theory. So he has at least solved different cases in America with this, and I believe in Nigeria, if we make use of this, clients will get healed or solved their problems. Okay, the next thing is trauma therapy. You know, sometimes we experience traumatic situation, event traumatic behavior also. So we can use trauma therapy. That is a treatment that helps a lot in changing traumatic disorder also. Relapse tendencies for those that are taking substances, you have to plan very well in such a way that it will help them so that tomorrow they should not be a victim of substance abuse or be a victim of this and that. Number five, define metrics, stroke monitoring plan. How progress will be tracked, e.g., rating scores, behavioral markers, client feedback. So there are this mechanism on ground. You can use rating scales, how somebody can rate you and say that you are moving slowly, faster, you are moving, not achieving anything, and so on. And not only this, behavioral markers. So there is need for us to understand this and client feedback. So even the client can track your progress, can say that yes, I'm making progress, I'm making headway. This particular problem, I'm getting out of it. So this is a sign, typical sign. Number six, specify sequences, stroke phases of, intervention. What comes first, second, and so. You have to look at it, sequence, very, very important. One thing at a time. And not only this, plan for contingencies. You have to plan for contingencies. If your goal is not being met, revise it or revisit it so that you can achieve something, that will really help you as a counselor. So a client needs to be helped. A client needs to be uh, uh, valued for or cared for so that his behavior can be changed also. Number seven, document in a formal treatment plan. So you can plan something like this: written plan shared with client and possibly legal stroke forensics stakeholders. May include baseline images, intervention schedule, responsible practice, and things like that. So these are some of the things that we are expected to note as counselors and so. Can we take a look at these tools and techniques, sort of methods for goal setting, treatment planning, and so? Number one, we have goal attainment scale, GAS, to qualify progress on individual goals. Number two, we have treatment plan template, standardized framework to ensure consistency. Number three, we have behavioral contracts, written agreement between clients and therapists. And not only this, we have safety, stroke relapse, prevention plan, especially relevant, uh, especially relevant where risk is present also. Number five is motivational interviewing to support client buy-in and resolve ambivalence. And not only this, number six, we have prioritization framework, e.g., ranking by agency, visibility, impact, and so. Number seven is SMART goals worksheet or template to ensure clarity and measurability. I think we have talked about small, SMART goal setting and so. Or example of treatment plans. If you take a look at the example, mini tablet, yes, table. Goal is number one, intervention is number one, metric, that's indicator. So let us look at it. Goal, reduce panic attack from 5 weeks or from 1 week to 5 weeks. So this is what you are expected to set for your goal. An intervention, what are you going to use in order to solve that particular problem? CBT with exposure plus breathing retraining. So these are the techniques, or these are the therapeutic procedure or therapeutic things that you're expected to do, so that you can help, you know, so that you can help a client solve his problem. Or if you take a look at the metrics or indicator, panic frequency logs, anxiety scale ratings can be used in order to at least determine the state of the, you know, the state of the client's well-being also. Improve social engagement. This is very, very important for a client to be at least to solve his social problem. What are you going to use? What kind of intervention are you expected to use? Social skills training from graded exposure. So this is a technique. You can take your time to understand what is social skills training stroke graded exposure. And not only this, number of outings, social satisfactions rating. So number of outings, you must take a look at this. And not only these, social satisfaction ratings is another thing that we're expected to know. Uh, if you look at this one, it's a continuation of what we've just said. Example one, goal setting, decrease daily depressive symptoms. This is what expected to do. If you take a look at the side of intervention, behavioral activation or activation plus cognitive restructuring. Cognitive restructuring is one of the best way of changing somebody's behavior so that that person will get out of his problem. Metrics or indicators, PSQ 9 score, activity log entries per day are expected to be used. And not only this, number three is improve sleep quality, target from 7 to 8. Sleep hygiene training are very, very important. So somebody that has improved sleep quality, that is, the person may have like from 7 to 9 hours sleep or so. If the person has problem, then there is need for sleep hygiene training. How do we do that? You help somebody to go and take some bets, but before taking bets, he should at least exercise his body by doing some exercise, 10 minutes, 20 minutes, so that the body will respond to what he's going to do. You go and take a warm water that is not highly warm also. You take that particular water so that you can reduce uh, the unnecessary whatever on your body. Before then, you can now take your sleep, but you are expected to sleep on your hand side. The sleep will come anytime. The next thing is sleep diary. Hours asleep, how many times or how many hours or how many minutes do you sleep in a day? Awakenings, you should know when do you wake up from sleep. And not only this, insomnia severity index. You can use insomnia severity index where to determine or to at least know the status of somebody's sleep also. The last thing is reduce alcohol use from drinks, from 1 to 5 drinks in a day. You can do something like this. So motivation interviewing plus relapse prevention plan helps a lot in reducing alcoholic use or alcohol use. Weekly drinking diary is good for a client to at least set something like this for his client. Days abstinent, where is expected to stop taking it, and audit score. Audit score is just you check what the person has followed and what he has not followed. So another thing is goal setting, intervention and metric. Increase assertiveness, interpersonal conflict, role playing technique, assertiveness skill coaching, number of assertive treatment in session, self self report, assertiveness call, manage anger outburst from 1 to 4 months, and not only this, anger management skills should be taught to the client. Mindfulness technique should be taught to the client. Calming strategy should be taught to the person. And anger incident log should be used. Anger scale rating should be used. Length of cool down period should also be noticed. Improves concentration and reduce distractibility. So what do you use? You use cognitive remediation, structured routine. If you take a look at the metric, score on attention based number of distractions per week or per hour. Okay, now next thing is goal, enhance self-esteem, self-worth, reduce social anxiety in public speaking, increase healthy exercise from 0 to 3 weeks. So if we take a look at the intervention, cognitive restructuring plus positive affirmation plus self-compassion practice, Number two, exposure therapy, gradual speaking tasks, cognitive reframing. The last thing there is behavioral activation from goal contracting or scheduling support. So if you take a look at the metric, Rosenberg self-esteem scale, daily affirmation logs, number of speeches given, subjective anxiety rating before after, and so uh, SUDS score, exercise log number of sessions per week, self-report energy and levels. So this is what a counselor is expected to do. So intervention, that is working space. This is the place where actual change strategies are implemented based on assessment and formulation. I've said it before, it is the most active portion of counseling, emotional work, behavioral change, skill building, exposure, experimental or experimentation. This is where you're expected to do that. The therapeutic alliance is tested, resilience or resistance may arise, interventions are tailored, monitored, and adjusted. So, even if there are difficulties, you should look at it very well in such a way that you can handle it. Techniques and tools. Cognitive behavioral therapy should be it should be understood. And not only this, dialectical behavioral therapy, uh, trauma focused therapies, exposure and behavioral experiment, role play, relaxation, mindfulness, motivational interviewing, monitoring via logs, scales, feedback, and loops. This is what you're expected to do. Okay, taking a very cursory look to this is key tasks function in the interventions or workshop or working space. So if you take a look at it, tasks stroke function, implement therapeutic technique, behavioral modification, and what skill training, exposure and experiments, in vivo work, real life tasks. So description, use choosing modalities. Okay, use choosing modalities, CBT, DBT, trauma focus, psychodynamics, etc., to address the formulation's target. Number two is teach coping skills, emotional regulation, social skills, problem solving, etc. Confront feared or avoided situation or behavioral experiments to test belief. So, if we take a look at this, it helps a lot. Okay, now you can transfer everyday situation, homework assignment, and so. And not only this, in vivo like real life tasks, addressing resistance and defense mechanism, maintain build therapeutic alliance of the ongoing risk management and social. So what you are expected to do in the intervention, you transfer skills into everyday situations, work, assignment, identify avoidance, denial, or other obstacles, work through them, monitor relationship, repair riches, ensure safety and trust, especially in forensic legal setting, monitor for risks to at least serve others exposure, legal compliance, and so. So this is the end of it. Thank you for listening.